Mr. Chairman, ladies and gentlemen, thank you. Thank you for inviting us back to Spain. It's wonderful to be here. We have so many friends, and we always look forward to coming here. It's also an honor for me to give the opening talk. And I'm going to discuss the epidemic of cardiovascular disease in the developing world and the implications for all of us who live in the developed world. But my interest in this goes back a long time to where I grew up in Zambia and then subsequently in South Africa. Now in 2002, if one looks at the global burden of cardiovascular disease, this is a World Health Organization study, total deaths in the world were 57 million. Of those, 16.7 million were cardiovascular, and 80% of those cardiovascular deaths accounted for 80% of worldwide cardiovascular deaths occurred in the low income and middle income countries. So the term that is now used for the developing world actually is this, the low income and middle income countries. In these countries, cardiovascular death occurred about 10 years on an average earlier than in the developed world, which has a big impact upon the workforce. By 2010, 70% of the elderly will live in the developing world. Now, I don't want to underestimate the importance of HIV, tuberculosis, and malaria, but we need to realize that the death rate due to cardiovascular disease is 3 times greater than all of these diseases put together. And cardiovascular disease is the leading cause of death, both in the developing world and in the developed world. Now, it's easy to see what has happened when you look at these figures from China. In 1973, I want you to concentrate on the green and the orange here. This is the death rate due to cerebrocardiovascular disease and cancer in China in 1973. And look what had happened by 2005. This has increased to this huge problem here. So this is being replicated in other parts of the developing world as well. And certainly China, the largest country in the world, is having a massive epidemic of cerebrovascular disease and cardiovascular disease and cancer, which is probably related to much of the environmental pollution, which is one reason why the Chinese government is attacking this so vigorously. This is a study from New Delhi, which is amazing, from Dr. Mark Huffman at Northwestern University. 1,100 participants aged 29 to 36 years. Look at the rise in overweight and hypertension and diabetes going back to about 1990. I've never seen anything like this. It's incredible. And in fact, even in rural China now, the leading cause of death is cardiovascular. Now, to understand this, we have to go to something called the epidemiologic transition, which was originally developed by Omran and has been elaborated on by others. The epidemiologic transition is a way of trying to understand what it is about society and changes in socioeconomic status that impact upon disease. And there are 4 stages of disease. The first is called the stage of pestilence and famine. And this would have been Europe in the 1800s and the United States. Malnutrition and infectious diseases, leading cause of death, life expectancy 35, proportion of deaths due to cardiovascular disease less than 10%, and most of these are infectious, like rheumatic heart disease. So this is where we all were maybe 150 years ago. And then stage 2, which is the stage of receding pandemics, is what happened to the United States around about the turn of the last century, 1900, and probably in Western Europe about 1920. Now we see improved nutrition and public health, chronic disease, and hypertension are now the leading causes of disease, and for the first time, hemorrhagic stroke appears as one of the major cardiovascular causes, but still rheumatic heart disease is dominant. Life expectancy 50 years. So from, at least in the United States, from 1900 to about 1920, the commonest cause of cardiac disease, of cardiac death, was rheumatic heart disease and infective endocarditis. And it's important to emphasize that many parts of the developing world are still in this stage, actually. Now, modern cardiovascular disease in the 20th century began with stage 3, the stage of degenerative and man-made diseases. And this was the United States from 1920 to about 1965, the epidemic of cardiovascular disease. Western Europe about 10 years later. Now the risk factors are increased fat and caloric intake, tobacco use, chronic disease deaths outweigh those due to infectious disease and malnutrition. Life expectancies greater than 60, and the proportion of deaths that are cardiovascular now go up from 35 to 65%. During this phase, the leading cause of death is ischemic heart disease. And stroke is both hemorrhagic and ischemic. But what is interesting in this phase of the epidemic, it starts in the high socioeconomic groups. In the 1930s and 40s in the United States, it was the wealthy professional people that developed the disease. And this is where much of the developing world is right now. Now, in probably the late 1960s and maybe 5 to 10 years later in Western Europe, we entered the stage that we are in now for most of the country. Stage 4, delayed degenerative diseases. The leading causes of mortality are now cardiovascular and cancer deaths. Infections have gone way down. Prevention and treatment delays the onset. We still have cardiovascular as the leading cause of death, but it now occurs in much older patients. But the age-adjusted cardiovascular death is reduced, so it becomes a disease of the elderly. And in fact, life expectancy now greater than 70%, about 50% of deaths are cardiovascular, and for the first time we see congestive heart failure. Now, in our own country, in the United States and other parts of the world, we actually have populations that are still in stage 3, and we have populations that are in stage 4. But in this phase, it is interesting what happens from a socioeconomic standpoint. In stage 4, the wealthy are the ones that are able, or the, let's say, more socially advantaged, are the ones that are able to concentrate on prevention and treatment, which delays the onset. So in the higher socioeconomic groups, it's a disease of the elderly. But premature coronary disease, parts of the United States like West Virginia and Appalachia, and the poorer areas of the country, Mississippi, their premature coronary disease occurs in those of a lower socioeconomic status. And so we in Western Europe, United States, stage 4, Australia, most of it stage 4, Japan, parts of South Africa, but the developing world, India, China, are very much in the middle of this huge epidemic that we had many years ago. So this is an example of what happens, and this is a paper that was published by Dr. Goyal and a number of us, Gabriel Steg, myself, Deepak Bhatt, who many of you will know. This is a registry of 61,000 patients with established cardiovascular disease or multiple risk factors. And what we did was we looked at patients stratified by their level of education, 0 to 8 years of school, 9 to 12 years, trade or technical college, and university or a college, as we call it in the States. And these are the associations with the attained educational level. And HIC are in the high-income countries. And what this graph shows, in the high-income countries, the higher the level of education, less obesity, less smoking, less hypertension, less diabetes, a little more hypercholesterolemia, and less polyvascular disease. But what happens in the low-income countries? In the low-income countries, the greater the level of education, the greater the income, the greater the obesity. Smoking didn't change except in females. Educated females smoke more. Hypertension, no change. Diabetes went down. Hypercholesterolemia went up. And polyvascular disease went up. So this is an example of what income and education does in people who are in phase 3 of the epidemic versus phase 4. And again, let me emphasize that 80% of worldwide cardiovascular deaths occur in the low and middle income countries, not the high income. Now, is there a phase 5? The negative impact of social upheaval and health regression. What effect is that going to have? And what about the age of inactivity and obesity, which is childhood obesity is such a problem in the United States and countries like Mexico. So this is a very depressing slide which shows life expectancy in Russia at birth, published in JAMA 1998. Now, if you look at this, you'll see United States females and Russian females in yellow and orange, US males and Russian males in yellow and orange. And to some extent, the two curves tracked for a period of time, and then something happened. US males continued to experience increased longevity, so did US females. Russian males here, during the time of perestroika, of great optimism in Russia, the Russian mortality or longevity increased, and then you saw the precipitous drop in mortality ever seen outside a world war. And what happened? This was the anti-alcohol campaign and perestroika from Gorbachev. Good thing. You see slight improvement in longevity. This was the collapse of the Soviet Union and a period of great economic and social instability, increased alcohol intake, increased tobacco, and furthermore, a reduced investment in healthcare. The Soviet Union cut back at that time its investment in healthcare. Heart disease and stroke accounted for 65% of the decline in life expectancy. What came second? Violence and accidents due to alcohol. What is encouraging, though, is that in the last 5 or 10 years, this is reversed. And these figures are much more encouraging, and longevity is increasing. But this is the impact of social stress on life expectancy. Interestingly enough, I've seen a study from St. Petersburg in Russia of university-trained individuals. They did not experience this. It was really the poor that were not ready to deal with the change in the economic system. This is a very disturbing paper from Ford and Capewell and illustrates another potential problem. It's not there yet, but it may be coming. Shown here is the estimated annual percentage change in cardiovascular mortality in males in yellow, age 35 to 44, and age greater than 55 in orange. You'll see in 1980 to 1989, if you look at younger individuals, 6% per year decline in mortality. By 1989 to 2000, 2% per year. And by 2000 to 2002, almost level. And the same thing in females, except by 2002, amongst younger females, there was actually an increase in mortality. Now, having said that, and this raised tremendous concerns around the world, because the epidemic of obesity is not just in the United States. In fact, the highest rate of obesity now is in Mexico, but it's also increasing in many other parts of the world, including Europe. The concern was that we're going to see the leveling off of the decline in mortality that we've seen for 40 years. The most recent figures published this year, though, from the United States still show a decline in mortality, but there is great concern about the potential impact of childhood obesity. Now, what about the developing world? This is a very important paper from Salim Yousaf's group, which illustrates the risk of myocardial infarction after adjustment for age, sex, and geographic region. Everything to the right of the line, increased rate of infarction, and everything to the left of the line, a reduced rate of MI. And what you see is across the world, because this adjusts for geographic region, across the world, in females and males, the risk factors are the same: current smoking, diabetes, hypertension, abdominal obesity, and the ratio of ApoB to ApoA1 ratio. All of these increase the risk of myocardial infarction by 2 to 4-fold. And then another index, which is interesting, the psychosocial index. And psychosocial stress is extremely high in the developing world as cultures try and adjust to a changing lifestyle. And this had a powerful impact on increasing myocardial infarction almost 4-fold. And then the good behavioral factors, fruits and vegetables, exercise, moderate alcohol content. All of these reduce the incidence of myocardial infarction. So what is important about this study is the targets for prevention appear to be the same across the world and across nationalities and cultures. And in fact, these 9 risk factors accounted for 90% of the population attributable risk of myocardial infarction. So Dr. Yusuf feels, and based on these data, that we can account for the epidemic on the basis of the traditional risk factors, and if we get rid of these risk factors, we will get rid of the epidemic, and that's probably partly true, but not totally true. And this is another part of the Yusuf study, the Interheart study, risk factors for early myocardial infarction in South Asians. And if you look at South Asians versus other countries, before adjusting for risk factors, you can see that the probability of having a myocardial infarction under the age of 40, about 10 for South Asians versus about 5. And then if you adjust for the risk factors, the difference falls away. So Dr. Yusuf's premise is it's all in the risk factors and it's not in the genetics, but I don't think that that's absolutely clarified. And this, for example, is the angiogram of a 35-year-old Indian male from the All India Heart Institute in Delhi. Look at this. Where do you, and I worked in South Africa for a considerable period of time, and amongst the South African Asians, this is what we saw. So it's not just the risk factors. There are other factors going on with some of these populations, and I think if you take South Asians and they get no risk factors, they may not get coronary disease, but once they do, there's a genetic vulnerability to coronary disease of such severity that we haven't seen it in any other populations. So there are the risk factors, but there is a genetic vulnerability. And from Jocelyn of the Jocelyn Clinic, this rather nice statement that genetics loads the gun, but the environment pulls the trigger. I agree, it's the environment and it's the risk factors, but some populations, at least the South Asian population in India and also in the United Kingdom, appear to be very vulnerable. Now, in this review that we published, we talked about a perfect storm. The potential epidemic of cardiovascular disease in developing countries is a perfect storm. First of all, you have a very hostile cardiovascular environment. Go to the big cities of Asia. Diet, lack of exercise. How do you exercise when it's 130 degrees in the shade in a city like Mumbai? This is a huge risk factor. Secondhand smoke and tobacco. The society is aging. We now have found out in the States that HIV survivors after 20, 30 years are getting premature coronary disease. What's going to happen in Africa when these people who right now die of HIV become survivors? I'll come back to air pollution in a moment. And then there are the tremendous psychosocial economic stresses of going from a rural to an urban environment and ending up in the slums that you see in parts of Latin America and Asia. And then there are other interesting factors that operate, and that's cultural values. For instance, in South Africa, which has maybe the highest incidence or one of the highest incidences of HIV in the world, it's not considered to be good to be thin. It's not. And in certain South African tribal cultures, obesity is a mark of status and wealth. So when you're trying to bring down the risk factors and reduce diabetes in a country where diabetes will double over 12 years, you have to deal with these cultural factors that run counter to what we try and preach. And then the role of the traditional healers. The other problem in the developing world is just simply a lack of national resources, a lack of infrastructure. And then there is the concept that I won't discuss, but it's in any detail, but it's fascinating. And that is the so-called thrifty gene concept. And that is, are certain societies, like Inuits in Alaska, Bedouins, Australian Aboriginals, the Pima Indians in Arizona, are these societies genetically vulnerable? Because it may well be that if you live on the edge of starvation, it may be a good thing to be insulin resistant because it keeps your blood sugar up. It may be good to be salt sensitive in a climate where you can get profoundly dehydrated, like in the desert. So this is very interesting. Many geneticists will say that this does not hold true. Others say it probably does hold true. And I do think that some of these populations are uniquely vulnerable to the stresses of 20th century life. And this is an example of what's happening. McDonald's hits Africa, and McDonald's is hitting the third world in a big way. What about air pollution? This statement from the AHA came out about 10 years ago, and then 2 years ago, this body of evidence has grown and been strengthened substantially since the first American Heart Association statement was published. There is no question that air pollution is a huge risk factor for cardiovascular disease. And in this more recent analysis of 2013, many of the potential mechanisms were discussed by Gold et al. I don't know if any of you will recognize this, but this photograph was taken 2 weeks before the Beijing Olympics. This is the Bird's Nest Stadium. And that's what Beijing looks like most days of the year. Fortunately, what happened with the Olympic Games, they banned all traffic, shut down all factories for 2 weeks. And then they were fortunate in that they got some thunderstorms and wind, and the Beijing Olympics went off in a non-polluted environment. But when you look at the developing world, 2004 World Bank top 20 most polluted cities, 12 in China, 5 in India, 1 in Indonesia, Cairo in Africa, and 1 in Thailand. And then when you look at the next 20 most polluted cities, where are they? In the exact same countries. So this is another risk factor that is perhaps unique to the developing world. And in terms of the thrifty gene, Dr. Gregg of the Rockefeller Foundation made this point. The human race has had long experience and a fine tradition in surviving adversity, but we now face a task for which we have little experience, the task of surviving prosperity. And really, the period of prosperity in Western Europe and some other countries in the United States, the period of prosperity is only about 200 years old. But for much of the developing world, the low and middle income countries, the period of prosperity is coming and just starting, but they have had a little experience in surviving that. How much coronary disease was there 100 years ago? Now, angina has been around for a long time. This is from the Ebers Papyrus in Egypt. Shouldst thou examine a patient with stomach disease suffering from pain in the arms and the breast and on one side of the chest, say death threatens. And that's thought to be maybe the earliest reference to angina. Heberden in the 1760s wrote about some account of a disorder of the breast. And then John Hunter, the English surgeon, said, "My life is in the hands of any fool who manages to put me in a rage." And he knew that when he developed, if he got stressed or angry or whatever, he was then aware of his symptoms of angina. And he died of a heart attack after an argument at St. George's Hospital. I'm not sure if this is true, but most people say he probably was arguing with a hospital administrator. And there's a fair amount of... But so angina's been around a long time. But what about myocardial infarction? What about coronary disease in the 1920s? This is an amazing statement from Sir William Osler in 1912. Angina pectoris, it is a rare disease. A case a year is about average, even in the large metropolitan hospitals. Even if they underdiagnosed it 20-fold. I mean, that's an amazing statement. And then there was an autopsy study in the United Kingdom prior to World War I, 1 to 2 necropsies per year with recent coronary thrombosis and AMI, acute myocardial infarction, at the London hospital. And then 40 years later, a 7-fold increase. Again, even if they missed it, it just wasn't around. And we're doing a study right now in Rochester where we have autopsy data at the Mayo Clinic going back to 1905. And I can tell you that in the 1920s, you were much more likely to die of infective endocarditis than you were of a myocardial infarction. And in fact, what came in around about that time were deaths due to stroke, but not myocardial infarction. And then this great comment from Paul Dudley White, the great US cardiologist. He was working at what is now Brigham and Women's Hospital, but in those days it was called the Peter Bent Brigham Hospital, and it served a blue-collar area of Boston, working-class area. And he says this, "The disease in my youth was hardly a problem, but I know that my professors did have occasional cases among their well-to-do patients whom they cared for at home." And I mentioned earlier, in phase 3 of the epidemic, the disease hits the wealthy or the better off. In phase 4, it's the poorer that get it. So this is, I think, in the middle of the epidemic, in the 1920s and 30s, or the start of the epidemic. And he says, we didn't see it in the hospital, but amongst the well-to-do in private practice, there was some angina. So there wasn't a lot around. So this is my interest in this, is through some work I do in South Africa with the foundation. And the big question is what's going to happen. Now, in the Heart of Soweto study, 1.1 million estimated people near Johannesburg, 85% of them are black, mean age 52.8 years, and 87 have cardiovascular risk factors. And in this study by Carr and Sliwa, if you look at the 1,600 new cases of cardiovascular disease diagnosed in 2006, coronary disease in 10%, and amongst the urban blacks, 6%. That's all. So amongst urban blacks in South Africa, there's very little coronary disease at the moment. There is some, but there's very little. Deaths due to heart failure, this is rheumatic heart disease. This is a mixture of hypertension, HIV, and cardiomyopathies. So the problem that a country like South Africa faces is they have an enormous epidemic of HIV to deal with. There is an epidemic of childhood and maternal violence and mortality that is very disturbing. South Africa can't deal with a massive epidemic of cardiovascular disease that India already has and China already has. So the question is it going to happen, or are they genetically protected? So the outlook for urban Africans, the current low rate in South Africa resembles the UK and the US in 1920. It's clear that in the 1920s there just was not a great deal of coronary disease around. African Americans in the 1980s probably had much less coronary disease. But the prevalence of risk factors in urban Africans is increasing alarmingly, especially diabetes, as it did in African Americans. And the question is, for a country like South Africa, will the morbidity and mortality rates be similar to African Americans? Because now African Americans have the same rate of heart disease as white Americans, if not higher. So this is what they have to deal with. Or is there a paradox? Is there a paradox? We've heard about the French paradox, Spanish paradox, the Japanese paradox. Maybe there's a level of genetic protection. Or is it just simply time will tell that over time, the Japanese, who have 1/4 the amount of coronary disease that we have, but is it just a matter of time? And that's the big question, and it's the question that's unanswered. But it is interesting to just speculate about genetic protection. This is the serum cholesterol and mortality in the so-called 7 countries study published years ago. Northern Europe, Southern Europe, the Mediterranean region, United States, Serbia, Southern Europe, inland, and Japan. And if you look at the rates of coronary disease, this is with a cholesterol of 200. This is Japan, and this is the Mediterranean, Southern Europe. I mean, it's hard to argue with these figures that you should lower the cholesterol in Japan. Why? I mean, there are other reasons perhaps for doing it. But it is quite striking, and for a cholesterol of 200, look at the difference in coronary disease mortality in Northern Europe versus the Mediterranean and Japan. So, the issue of whether there's some level of, whether it's genetic protection, lifestyle protection in Africa and other countries is still unresolved. This is a study from Spain of 2,270 individuals, and the presence of risk factors is high. And this is Mediterranean Spain, Malaga. Smoking, hypertension 33%, dyslipidemia 65%, 60% overweight. But as you look at the figures for Europe that have recently been published, the age-standardized mortality per 100,000 of the population, in fact, Spain, amongst males, is the third lowest, and amongst females, it's the second lowest, despite the presence of risk factors. So these are questions that are still looking for answers that may be important for some of the developing world. Now, how do you prevent it and what do you do? Now, the Framingham study published its report in 1961. It identified hypertension, hypercholesterolemia, and smoking as risk factors. Within years, a few years, the NIH and the American Heart Association and the Surgeon General had national programs to address these risk factors. And by 1967, the epidemic of cardiovascular disease in North America began to decline rapidly and dramatically, and it followed 5 to 10 years later in Europe. So I think the Framingham study provided the National Institute of Health and the country, and I would say the world, with a huge return on its investment. We now knew what the targets were, and we then had programs to address them. And this is one of the most interesting papers that I think has come out. We know that mortality has declined over the last 40 years, but has the incidence of coronary disease declined? And this is a study done on United States military people who died during combat or of unintentional injuries. And this autopsy study illustrates the prevalence of atherosclerosis in the Korean War, the Vietnam War, and then more recently. And what was so striking in the Korean War, where the average age was 22, was that 15% of these young soldiers had in yellow severe coronary atherosclerosis. By the time and any atherosclerosis was present in 77%. By the time of the Vietnam War, it had declined, and more recently, it has declined dramatically. So these programs clearly are having an impact both on the development of atherosclerosis and the mortality due to coronary disease. It's been very, very striking, and this is a very recent study. Equally important, and in terms of what we need to do in our own environments, is this study from Ford. He took a whole series of studies in countries that were able to look at the decline in mortality due to coronary disease. This is from the Monica study and others. And then they developed a model that looked at what proportion of the decline in mortality was due to new treatments, risk factors, and unexplained. And the ones that are the most fascinating, I think, is Poland and North Karelia in Finland. Now, in the 1970s, the highest incidence of coronary disease in the world was seen in North Karelia. And in fact, Scandinavian epidemiologists used to use the word Karelia as a risk factor in itself. It was so high. And look what happened over and this is Poland more recently, but this is the impact in North Karelia. 73% reduction in ischemic heart disease mortality from 1971 to 1995, and most of that was due to changes in risk factors and not treatment. So we know what to do. Same actually interesting data from Spain, analyzing the coronary heart disease mortality decline. This is the decline due to therapies, and this is the decline due to changes in risk factors. And if you look here, it's about 50-50. About 50% of the decline was a change in risk factors, and 50% a decline due to changes in treatment. But certainly in a country like Finland, it was 75% change in risk factors. Now, how quickly does it take to change? And this is an amazing study by a woman called Catherine O'Day and Alex Brown, who work in Australia, in the Northern Territory of Australia, where there's a very high Aboriginal population. What they did, and amongst this Aboriginal population, The average age of death is about 18 years younger than white Australians. Terrible figures. 18 years less. And what do they die of? Diabetes and violence. And so what she did, she took 10 Aborigines from Derby, Western Australia. I've actually been to this town, which is not a very nice place. They were diabetics, and she sent them into the bush to their hunter-gatherer lifestyle for 7 weeks. They became hunter-gatherers, because these people were originally hunter-gatherers until they were brought into reservations. And this is what is amazing. Amazing. The major metabolic abnormalities of diabetes were either greatly improved or completely normalized in 7 weeks. This is very encouraging. It can be done. And then the other encouraging piece of data comes from Cuba. Now, in 1989 to 2000, as you will know, Cuba went through a real economic crisis when the Soviet Union collapsed, the American blockade, and things were in very short supply. Food, gasoline, so on. Look what happened during that time. This is the period of economic the crisis. Look what happened to type 2 diabetes. And I think the study by Franco, I think may have been published in Spain. Look what happened to coronary heart disease. Look what happened to cancer, no change. And look what happened to all-cause mortality. And look what's happening now. Look what's happening now. They're over that economic crisis. Maybe it's going up again. But this is very striking. It shows that you can alter disease patterns in 10 years by controlling risk factors. So to conclude, how do you do this in the developing world? And the answer is very simple. It is extremely difficult. And there are two approaches: population-based versus individual interventions in high-risk populations. The World Health Organization has finally realized, that more of us will die of cardiovascular disease than of mad cow disease. Finally, they've realized that swine flu is very frightening and SARS is very frightening, but it's not going to kill nearly as many people as cardiovascular disease. So finally, the World Health has really accepted this and made it a priority. And in terms of population-based, these are the targets, what they call the so-called best buys. Now, to do that, to change tobacco consumption and alcohol, in China, the leading manufacturer of cigarettes is the Chinese government. So if you're really going to change these things, it's not just going to be done by doctors and patients. You need industry and you need legislation. And without government and political backing, it's not going to work. The other approach in a country like India is you try and identify, well, not just India, high-risk populations, lipid-lowering, blood pressure control, platelet inhibitors. And what is really interesting is to see what will be the role of the polypill, which is currently under trial. Part of this is that healthcare providers must lead by example. Now, this may not be what you think it is. What it is it's the Chinese National Cardiac Society Congress, and everybody there is taking an oath that they won't smoke, no one in their hospital will smoke, and no one in their family will smoke. That's leading by example. And this was taken in Uruguay. Now, obesity is a major problem in Latin America. And at the Cardiac Society Congress, the physicians drew attention in this rather unique way to the obesity epidemic in the country of Uruguay. But physicians have to lead by example and not just by promulgation. So my concluding slides are these. These are two new economic studies. If we do not do anything about this in the developing world, and this is from the United Nations Summit, the cost of business as usual, if things just go on the way they are, and the epidemic in China and India continues, the cost will be $47 trillion over the next 25 years. The cost for the low and middle income, this is for the world, for the low and middle income countries alone, it'll be $500 billion or more per year. The World Health Organization study came up with this. The cost of basic prevention at a primary care level in low and middle income countries is $2 billion. And the cost of secondary prevention and treatment is $22 billion. So the maths is inescapable. So to conclude, why should rich countries, and all of us in the West come from rich countries, it may be in matters of degree. But why should we really care about the world's least healthy people? Well, there are very good reasons. First of all, it's very much in our international and national self-interest, because healthy countries, stable countries, promote trade and stability. And health has been strongly associated with stability in a number of studies. So it's very much in our interest to control these epidemics around the world. They don't need aid, they need trade. And then, of course, we have a moral and an ethical obligation. So I thank you again for inviting me to be the opening speaker, and I'm very pleased to be back in Spain and look forward to the meeting. Thank you.